Good evening, everyone. It's with immense happiness that we welcome you all to this webinar on suicide prevention during COVID-19. The Department of Psychiatric Social Work, NIMHANS, under the guidance of the current head and Professor Dr. Dhanashekhara Pandit, has been involved in suicide prevention and gatekeeper training for some time now. And this webinar is also an effort to throw light on the predicament that suicide poses, especially during these troubled times. So we have with us two eminent personalities in the field of suicide prevention, Dr. Lakshmi Vijayakumar, who will be the presenter for the day, and Dr. Prabha Chandra, who will be the chairperson. So I invite Ms. Anjana and Ms. Shangavi, who are MPhil scholars in the Department of Psychiatric Social Work, to introduce our guests. Dr. Lakshmi Vijayakumar. She is the founder of Sneha, an NGO in Chennai, India's Suicide Prevention Center, found in 1986. And she is the head Department of Psychiatry, Voluntary Health Services, popularly known as VHS, Adayar, Chennai. And she is also the member of the WHO's International Network for Suicide Research and Prevention, and also a member of the International Academy of Suicide Research. She is also an honorary associate professor in the University of Melbourne, Australia, and honorary adjunct professor of University of Griffith, Australia. She has been awarded the honorary fellowship of the Royal College of Psychiatrists, UK, for her work on suicide prevention, and also has been conferred FRCP. She has also been awarded with Ringal Service Award by the International Association for Suicide Prevention, IASP, in June 2015. She has published widely in peer-reviewed journals and has authored several chapters and edited 2 books. It is my privilege to welcome you, ma'am, on behalf of all of us to this webinar. Once again, welcome you, ma'am. We take the immense pleasure of welcoming Dr. Prabha S. Chandra, who is the professor and former head of the Department of Psychiatry, NIMHANS, Bengaluru. She has been awarded the Fellowship of the Royal College of Physicians of Edinburgh, the Fellowship of Royal College of Psychiatrists, and the Award of Fellowship of Academy of Medicine, Singapore. She is the president-elect of the International Associations of Women's Mental Health. She has served as a temporary advisor to the World Health Organization and UNAIDS. She is a visiting professor in the University of Liverpool. She worked at the Mother Baby Psychiatric Units in UK. She is working in the field of perinatal psychiatry since 1994 and heading the perinatal psychiatry clinic in NIMHANS, Bangalore. She is the section editor in the Archives of Women's Mental Health. She is also the in charge of the NIMHANS Center for Wellbeing, a youth-friendly mental health service which organizes a regular gatekeeper training program for suicide prevention and other areas of mental health. She has also published several articles and edited books. We welcome you, ma'am. Thank you.
Hello.
Before we proceed, I request you all to mute yourself throughout the presentation, and all the questions and clarifications can be typed into the chat box, which will be attended to during the discussion session. So this initiative, the webinar, would not have materialized if it wasn't for the relentless efforts of Dr. Dhanashekara Pandian, Professor and Head, and Dr. Anish V. Cherin, Assistant Professor, Department of Psychiatric Social Work, NIMHANS. So I now invite Dr. Dhanashekara Pandian to address the gathering.
Good evening. I'm extremely happy to welcome all of you for the webinar on suicide prevention during the COVID-19 pandemic. This is organized by the Department of Psychiatric Social Work, NIMHANS, in collaboration with the Telemedicine Center of NIMHANS, Bengaluru. I have the privilege of having two eminent personalities who are consistently working in the area of suicide prevention in the country. The presenter for the today's suicide prevention program, the during COVID-19 pandemic, by Dr. Lakshmi Vijayakumar, Director, Sneha, Chennai, and Dr. Prabha Chandra, Professor of Psychiatry, NIMHANS, Bengaluru, has kindly agreed to be the chairperson and initiate this program. On behalf of the Department of Psychiatric Social Work, NIMHANS, I welcome all of you for this program. As we all know, National Institute of Mental Health and Neurosciences, NIMHANS, has a very important status, not only in the country, but all over the world in providing higher quality of healthcare services, human resource development, research and training in the area of mental health and neurosciences. NIMHANS is also focusing on all aspects of physical and psychosocial well-being of our clients and their family members with its dedicated multidisciplinary team of medical and paramedical professionals. Psychiatric social work team is an integral part of this multidisciplinary team of professionals and has been instrumental in providing psychosocial care and services for persons and families affected with mental health issues and neurological disorders. The Department of Psychiatric Social Work services were initiated at NIMHANS in 1963, and since then the department has been providing preventive, promotive, and curative health and mental health services for different sections of the population in the country. The department is well known to be the pioneer in conducting various collaborative service and research activities with national and international agencies and has taken a leading role in conducting many capacity building training programs on pertinent psychosocial issues. The department also has initiated many networking and collaborative activities with various national and international organizations in providing a high quality of psychosocial care and support services for the marginalized, victims of trauma, discrimination, and people with various distress. During this COVID-19 pandemic, NIMHANS, the entire team of NIMHANS, we strongly believe that this COVID-19 is a kind of a wake-up call for the entire discipline of mental health. In fact, psychiatry, psychology, psychiatric social work, and all other disciplines, we have to take many measures to take care of the issues actually. In fact, our beloved professor, Professor Ravi, our senior professor of neurovirology, cautioned the entire country that this pandemic is going to affect significant percentage of our population even in the month of May 2020. So he said the pandemic will not go away just like that, and we have to take all kind of precautions. As a result of as a kind of an activity during to deal with the COVID-19 pandemic, NIMHANS has initiated many innovative programs for the welfare of people in general and the persons with mental and behavioral disorders in particular. Some of the activities of NIMHANS are continuum of care program for persons with mental health problem and neurological disorders, the telemedicine services and the tele aftercare services, interactive voice response system IVRS, addressing the mental health issues of the migrant laborers, and NIMHANS as a nodal organization for Government of India. NIMHANS has provided telecounseling services to more than 3 lakh population through psychosocial support in mental health services in collaboration with the various other governmental organizations like CIP Ranchi and LGP and Tejpur and other organizations under the supervision of Dr. K. Segar, Professor of Psychiatric Social Work and Registrar of NIMHANS. We at the Department of Psychiatric Social Work NIMHANS strongly believe that this COVID-19 pandemic will not pass quickly and it will have a major impact on the quality of life of our population in terms of their mental health, unemployment, economy, stress, vulnerability, and other related social problems. As an impact of our population also will have an increased level of anxiety, depression, alcohol and substance misuse, intimate partner violence, ideas of hopelessness, worthlessness, and helplessness that would ultimately lead to suicidal wishes, suicidal ideas, suicidal thoughts, and suicidal attempts. Initiating suicide prevention activities, it's a need of the hour. In view of this, the Department of Psychiatric Social Work NIMHANS, Bengaluru, has initiated this webinar on suicide prevention during COVID-19 pandemic. I once again welcome all of you for this webinar on behalf of the department and on behalf of the NIMHANS, entire fraternity of NIMHANS. I request Professor Dr. K. Sekhar, our senior professor of psychiatric social work and the registrar of NIMHANS, to have his observation and as a part of this initiation of this activity. Over to Dr. Sekhar.
Thank you, Dr. Pandian, for that small little opportunity. I don't want to take much of the time of the large number of almost touching 500 participants. We have large things to talk about and hear. At the outset, I congratulate the mental health team of NIMHANS, especially the Department of Psychiatric Social Work, for picking up this issue with two of the major giants in this area, Lakshmi Vijayakumar of Sneha, about whom you have all learned. I would like to say on behalf of both the ministry as well as on behalf of NIMHANS that she is one of the honorable members of the National Task Force on guidelines for psychosocial support and mental health services in COVID-19 situation. Her contribution is so much that she enriched this particular document with a large amount of annexures and other issues. Madam, we have included most of the things, whatever you have spoken about, and we are further working on to it. I would like to learn the lessons from this particular webinar. If any of the loose things, whatever we have kept, can be also put together in the current guidelines per se. And Prabha Chandra, she is one of the senior most faculty in NIMHANS who has also been instrumental in doing the gatekeepers interview, which today has helped a large number of persons to be trained and how to go about, including the lay persons, how they can be roped in for suicide prevention activity. Now, the only message, threat of COVID-19 is able to create a large amount of opportunities, which we all, the 500 members here who are logged in and those who are going to log in, need to spread over not to just 500, but to almost about 50% of our total population in the country in whatever means and other things in a scientific manner, what we are going to learn from Lakshmi Vijayakumar today. And it is just not a mental health issue. It is more currently in terms of the psychosocial situation, including that of a joblessness, the work, the economic situation, the family situation, health of that particular member and their family members, and a large amount of the other issues which compel them at the moment of a thing. But it will be better always for us to intervene in this situation. And let me ask Dr. Prabha and Vijayakumar to have that share of a time, which is going to be more learning as well as for us to move further on. Thank you.
Thank you, sir. I also have the great honor. There are more than 500 participants from all over the country and all over the world. And very specially, I have the great honor to welcome Sri Alok Mathurji, Additional Deputy Director General of the Office of the Director General of Health Services, DCHS, Government of India, New Delhi. I also have the honor. We also have Dr. Atrey Ganguly from WHO's country's office, New Delhi, and both have joined together in the meeting. I request Dr. Alok Mathur ji to have his remarks, please.
Thank you, Dr. Pandian. And I would like to congratulate you and your department for carrying out so many activities that you had just enumerated a few minutes back. And I had the honor of attending, Saturday's webinar also, in which our secretary madam had also participated, in which the director Dr. Gangadhar had also mentioned a number of activities that your esteemed institute had carried out and is still carrying on during this pandemic. My congratulations to you and your department, to all the faculty members.
Thank you, sir.
Coming on to this webinar, and again, my congratulations to you because you have chosen this topic. This is that is suicide prevention, and this is very relevant because during this pandemic and even after that, uh, attempt to suicides are likely to increase, and there are so many issues involved, like Dr. Shekhar had just said. There are beyond mental health and mental illnesses, there are other issues also involved in such in suicide attempts and completed suicide. These are social issues also. So we can say the psychosocial issues involved in this suicides and attempts suicide, these are very relevant. And uh, for your knowledge, we are in the process of finalizing a suicide prevention strategy. That would be a national suicide prevention strategy. In fact, in the morning session before lunch, we were in the process of finalizing the implementation framework to it, because along with Dr. Lakshmi and other members of the task force that the ministry had constituted, we had finalized the actions, the various actions, that the various stakeholders would carry out, because this is a multi-sectoral approach. If you want to prevent the suicide, you need to approach various sectors, various agencies to implement those actions, those activities. So we were in the process of finalizing the implementation framework, because if we share the actions to various stakeholders, then that won't alone be sufficient. We need to give them how to implement those actions also. So we were, fine tuning all those actions along with their guidance, their implementation framework and all. And very soon we would be out with that document. I would like to assure all the contributors, the task force members, that the ministry is working on it, and that too on top priority basis. Then we would soon be having a national suicide prevention strategy. And as you all know that one of the the indicators of target 3.4 health is also the suicide. We need to reduce the suicide rate. So keeping all these things in view, uh, uh, I hope that we soon would be having a very comprehensive document in which all the stakeholders will be requested, will be guided to implement those activities, so that in the coming years we will have less and less of suicides in the country. Thank you so much, Dr. Pandian. I wish all the best.
Thank you very much, Alok Mathur ji, for your valuable observation. Now I request Professor Dr. Prabha Chandra, Professor of Psychiatry, NIMHANS, Bengaluru, the chairperson for the today's webinar, Suicide Prevention during the COVID-19 pandemic, to take the session and conduct the session, please. I request Dr. Prabha Chandra, please.
Good afternoon, everybody, and it is such a pleasure to be in this audience and with so much active participation. I thank Dr. Professor Pandian and Dr. Anish Cherian for inviting me and for all the good work that they're doing. I think 20th of July is going to be really like a very important day, because we've just had Dr. Alok Mathur saying that, declaring that the National Suicide Prevention Policy is going to see the light of day and is going to be a reality. And we have the best speaker possible on this topic in the webinar. I must also mention that while on the screen we are seeing 500 participants, there are actually another 500 watching on YouTube. So I think the very fact that there's so many people who have tuned in, who are participating into this topic, indicates the relevance and importance and how it's touched each one of us. I think it's, interesting that pandemics and disasters bring out the importance of mental health. I mean, till then, mental health is not really in the forefront. Other conditions are in the forefront. But the moment there is a pandemic or a disaster, we start talking about mental health. And in a way, it's good that we do, because it becomes more and more relevant. When there was HIV, we started talking about counseling. We started talking about mental health. Till then, infectious diseases and mental health were hardly combined with each other. When the tsunami struck, we started again talking about mental health in a slightly different way, the role of trauma. And now with COVID, I think the one condition in mental health which has just come to light and is so important is the area of suicide, which is being called a shadow pandemic. But I don't think it's any longer a shadow pandemic. I think it's actually side by side as much as COVID-19. We are actually seeing what is happening around us, and there are so many interesting issues. In fact, a lot of the people who might have tuned in may be students of social work, sociology, psychology, and of course medicine. And I was reading an article today that if Emil Durkheim, the sociologist who talked about suicide, was alive today, what would he have to say? And maybe that's a question I'm going to ask Lakshmi at the end of her talk, about what would be his analysis of this whole, what's happening. And like Dr. Alok mentioned, this is just not a medical condition or a mental health condition any longer. It has wider ramifications, just like COVID-19 has wider ramifications. So I think we are very eager to listen to Dr. Lakshmi about her analysis of the situation. What are the factors which are contributing? Indeed, is there an increase in suicide? And then something about the possible solutions, and what the national response should be, and what each of us should really do. Before I ask Lakshmi to talk, I'm also going to tell people that this may be a triggering talk. There may be people out there who are distressed, and the talk about suicide, if in some ways it's triggering, then please feel free to reach out, and Dr. Anish will show you the helpline numbers at the end of the talk, so that if anybody needs support and help, they can reach out to us. Dr. Lakshmi is a champion in this area, and I invite her to speak, after which we'll take questions. I think the session is going to go on for a bit. So please feel free to write your questions on the chat box, and we will try and address as many questions as possible. Dr. Lakshmi, over to you.
Thank you. Thank you very much. It's a real privilege to be chaired by Professor Prabha Chandra, and an honor to have Dr. Alok Mathur, who has really championed mental health for our country, and also right now championing the National Suicide Prevention Strategy. It's easy for us to write, but to make it implement, to go through the official process, to make it happen, we need people like Dr. Alok Mathur to make that happen. And I'm particularly thankful to NIMHANS for giving me this opportunity, Dr. Shekhar, Dr. Pandian, and the brain behind this webinar, Dr. Anish Cherian. Thank you for giving me this opportunity. So I'll start sharing my screen if it's okay with you. So I'm just going to go to this first slide. Okay, this I'm sure many of you would have known. This is the suicide map of the world, and as you can see that Unfortunately, in India, we are sometimes probably even more higher than many of the developed countries. India, Russia, the Baltic countries, we have the highest suicide rates in the world. And this is a corona map of the world. And here we have other countries also which have high corona rates like Germany, Italy, France, Brazil, USA. But what we need to understand is if you compare the previous map to this map, you will see that there are two countries which have both high suicide rates and both high corona infections, and that is India and Russia. And unless we take a proactive stance to reduce this, as Prabha rightly called, not anymore a shadow epidemic, but a coexisting epidemic of suicide, we will be losing more lives in this coming years. So this is the suicide map of India. This is from the NCRB 2018, and this pattern has been persistent in India for the last 20-30 years, where the southern states have the highest suicide rates, the middle states have middle rates, and the northernmost states like Bihar and Uttar Pradesh, they have the lowest suicide rate. This has been persistent for almost the last 25-30 years. And this is the corona map of India. And again, Tamil Nadu, which has a high suicide rate, has increased COVID. Maharashtra, which has a highest number of suicides, have high suicide rates. Gujarat and Delhi, and now, of course, even Telangana, which has a high suicide rate, there is an increasing amount of COVID. So again, we have to be careful in states which have a high suicide rate. When there is a high prevalence of COVID, then it becomes double danger. So what about pandemics and suicide? What evidence do we have? See, the Spanish flu killed millions of people around the world. And 84 cities in USA were studied even at that time. And the suicide rates increased. More recently, following the SARS epidemic, there was an increase in suicide in the older people in Hong Kong, not for other people, but the older people in Hong Kong. What about the COVID? The early preliminary results shows a little decline in New Zealand, Japan, and United Kingdom. And in fact, Dr. Atreyi would also agree that we saw some slides from Thailand which showed a little bit of dip when the conference was there. But this is the early stage. And to answer to Prabha's question, you would say the early stages of any disaster, in the early stages of any problem, there is a sense of, Durkheim's theory is based on social integration. How well you are integrated into the society determines your suicide potential. So during times of war, during times of the disasters, there is a sense of togetherness and suicide comes down. But actually, if you look at it, it is only the early phases. In the later phases, it changes. When you have the economic sequelae, then the suicide rate goes up. And even now, during COVID, we now find that certain regions, for example, Queensland in Australia, where they are tracking the suicides on a weekly basis, have shown an increase. And Brazil, which had a fairly low suicide rate, is showing an increase in suicide. So it is a kind of a mixed bag currently. So unfortunately, we have the dubious distinction of reporting the first COVID suicide from India, from South India. On 12th of February, from South India, Kerala, a person died by suicide thinking because he had some flu-like symptoms, he thought he had COVID and died by suicide. The first case of suicide homicide happened in Chicago in May, where the person shot his partner and then himself, thinking that both of them have suicides. It is believed that at least in the next 10 years, there will be 75,000 additional suicides for every 3 years, which is a phenomenal number. And they say it may be an underestimate. So what are the factors associated with suicide? I am sure we all know this, the fear of infection, the social stigma. The social stigma is quite significant. Just like how HIV was initially, COVID has become like this. People are barred from entering their apartments. People are barred from going to their villages. People who have COVID are not even are rejected by the family, and that affects them more. And the stigma attached to the COVID has a significant contribution in making a person feeling rejected. And we know that feeling rejected is one of the most important factors which triggers a suicidal behavior. And also all this distancing, physical distancing, quarantine, which we all know about, okay? And the usual support systems of family, friends, gatherings, or even religious contacts are all denied to us because of the lockdown situation and the fear of COVID. So on one hand, the loneliness, the distancing, the stigma, the fear has increased. On the other hand, at the same time, the support system, or what shall I say, systems which we use to reduce our stresses have come down. So it is a combination of both which causes suicide. Of course, financial insecurity. Just as Durkheim said that suicides are less during times of war, during times of economic turbulence, suicides increase tremendously. For example, we know about increase in suicide during the Wall Street collapse, during the 1980s dot-com bust, the Asian tiger collapse. In the Asian tiger collapse, there has been an increase of 16,000 suicides. And some of the countries like Korea, South Korea, which had low suicide rates, had a high suicide rate during the economic turbulence, and that rate has remained even now high. So that is and the prediction for this COVID is that we are going to go into a recession. We are going to have a huge economic crisis in the coming months and probably years, and that would have a correlation with suicide. And insecurity, see, uncertainty. As human beings, if we know that yes, whether we are pass or fail, we'll be able to deal with it. But not knowing is what affects us most. Okay? Not knowing, uncertainty is what affects us most. And the future insecurity. See, we do not know when we are going to go to school, colleges, when we are going to go and watch a movie, when we are going to go to the temple or church, when we are mass, when we are going to go and have a wedding. So nothing is known. So the future insecurity means that we don't have a control over it. So suicidal people, one of the important factors or a personality characteristic of a person who's suicidal is that they have an external locus of control. They feel they cannot control anything, and events are happening over which they have no control. And today it really is happening. There are a lot of situations we don't have any control, and so their helplessness increases tremendously. And then because of the COVID, there are barriers to health services and mental health services particularly. And what can I say about media influence? Okay, media has not been anything but sensational. Okay, every day we open the paper, every day we look at the TV, it is 10,000 more people, 25,000 more people contract COVID. But I haven't seen one headline which says 5,000 people recovered from COVID, 10,000 people recovered. But 50% of people more than 60% of people who had COVID have recovered. I haven't seen that kind of headline. It comes in a small, like a statutory warning, it comes in a small thing. So the media has really created a lot of panic in the people. And I wish the media has used this to educate the people rather than creating panic. And unfortunately, in our country, during this time, we had the unfortunate death of a famous Bollywood actor, which has made things even more difficult, more sensationalistic reporting, more lack of empathy to the family members, and so on. So who are the vulnerable population? If you look at it, it is the elderly. The elderly are a vulnerable population. The thing is that they have comorbidities, so they have the case fatality is a little bit more for them. They are alone. Many of them are denied the kind of services which they are used to, like having maids or helpers, and so they end up doing and developing physical issues, and they feel that they are a burden. You know, the only saving grace which I can think of is the fact that in India, the above 60 have a low suicide rate, and I hope that it stays. But if the elderly are becoming vulnerable, they are feeling more lonely, they're feeling more isolated, and if they feel that they're being a burden to the society and the family, and they feel that they are losing their independence, this rate may change and we may start seeing an elderly suicide. So we have to take proactive measures to address this issue. Persons with existing psychological problems. These are people who have limited access, medication, treatment, and all their symptoms have become exacerbated. Particularly people with obsessive compulsive disorders, this COVID has really made them their symptomatology worse, and they are finding it extremely difficult to cope. And other vulnerable population which flies under the radar, which is not often talked about, is the mental health of the health professionals, people working in the COVID areas. Recently, just last week, I had a doctor, a very sincere, conscientious, hardworking doctor working in government service, who was posted in COVID ward. He did his duties properly, came back, was in isolation for a week at home because he had two elderly parents. And then he is due next for another posting. And then there was pressure from the family saying that please ask for an exemption because you can't, you have two elderly parents at home, you have to look after, you may bring the infection back, so please ask for an extension. So he went and asked for an extension, and the HOD gave him the extension because he knew that he's not a shirker and he is a very sincere and hardworking person. Having got the extension, unfortunately at the same time, a person who was in quarantine jumped from his hospital and died by suicide. So he came back and he was feeling extremely guilty. On one hand, he feels he had to go, he's a conscientious daughter, so he wanted to do his work, he wanted to do his job, he wanted to be useful to the society at this time of crisis. On the other hand, he has to look after his parents, and he is caught, and he felt that he was not doing, not worthy of being a doctor because this was he's hiding behind, he's shirking his duties, and his friend described the suicide of the patient, and that immediately kept on him, so much so that he started having he started having things that maybe he should die, he's not fit, he's neither fit as a doctor nor is he looked, and he gets angry with the parents because of them only he's not able to do. So I'm neither a good son nor am I a good doctor. So he became so much, he realized there's something really seriously wrong, and he came to me for help. And what he told me was, it is not only me, there are a lot of us who are caught between wanting to do your work and wanting to protect your family. And what he said was very interesting. He said, yes, they call us warriors, doctor. In the war, the soldiers go alone and battle. But here, we bring the war back into home, and that is causing us the maximum anxiety. So, and the healthcare professionals need the proactive help at this point of time. And we have all seen the plight of the migrant workers. I don't have words to say, but I think this is the, somebody said that this is the maximum internal migration which has happened after the partition, and the stories which we heard, the tribulations and trials, and for all, when they go back to their village, they are not welcome back. They are not, many villages don't allow them back. They lose their job, they lose their economic independence, they are not welcome back. It is a terrible situation. We have not really counted the number of suicides in our migrants, but Kuwait has. Kuwait normally has about 70 to 80 suicides a year. But in just 3 months, they had 40 suicides and 15 attempts, and 99, excepting barring one, all of them are migrants from India. So they have all lost a job. They have not been paid for the last 3 months. They live in difficult circumstances. They can't get back to home, and they are in a terrible state. And the other thing which is not really under the radar, which is out in the open, but nobody is doing anything about it, is experience of the domestic violence. The domestic violence has increased tremendously right around the world. Many domestic violence people are calling. Even in our country, the domestic violence has increased. The lack confinement, the lack of ability to get out. Even if you want to escape for a few hours, you are not able to escape. You are not able to go to your mother's house or your friend's house and escape the violence. It's not possible. But actually, if you look at it, Canada has booked 10,000 hotel rooms right around Canada, so that if any women wants, she can just go there for the hotel for 2-3 days till situation becomes better. So this is a chart which is prepared by Cher, which kind of gives an idea about how suicide is developed during this COVID. So you have the uncertainty, the financial issues, and how it affects the vulnerable people, and how these vulnerable people, as I said, people who live, what is interesting is what this COVID has shown us is that people who live in high COVID prevalent areas are more vulnerable to suicide. Okay, so people who live in containment areas, or people who have a family or friend or somebody who was lost to suicide, are more vulnerable. That research has come through. And how this can lead to the kind of psychological issues which can trigger a suicide. Looking to our own country, this is the first publication or research which has come from India, and it has been published in Psychiatric Services in May, where they have followed up people from the newspaper and found that there were 69 people who have committed suicide in those 3 weeks. And 60% of them are due to fear of COVID and financial crisis. Dr. Soumitra Patare and myself, we have also done a study. We have sent it for publication, and since it is under review, I'm not able to give you the full details of the study. But we have also tagged the top 10 newspapers during the initial strict lockdown throughout, and we have found almost about 350 suicides, which has been done in this from the 24th of March to the 3rd of May. And what is interesting is that there has been a shift in the demographics of suicide. Now, it is no more the young females who are suicide. Now, we are seeing middle-aged, and majority of the suicides are by males. And majority of them are employed. So the fear of the economic loss or loss of job, or reduced economy, reduced earning potential has really weighed in on them. And this is the change in demographics which we have seen. And also in methods, because the trains didn't work, we had no hanging. We had no jumping in front of trains, but hanging had increased. And because farming activities were stopped, pesticides had come down a little bit, but after the first lockdown, farming has increased, so we have to wait and see how it is in the later years. If at all, I have to say there is this tiny silver lining to this entire pandemic. I think it is the suicides due to exam failure. Every year, we lose at least 2,500 students to exam failure. Okay, but because of this COVID, many exams are cancelled, and we have had maybe 1 or 2 cases, which means actually 2,400 young lives have been saved, which should make us think Where have we gone wrong in our education system? Is the 1-point entrance exam, is it entrance exam or end exam, is it relevant? Or should we go in for a continuous assessment? Because that really seems to save many lives, young lives. The other thing which we found in our study was that alcohol-related suicides are pretty high. You know, it was a compulsory withdrawal from alcohol because all the liquor outlets were stopped. So many people went in for withdrawal, and because of withdrawal, there was a lot of domestic violence. And during the withdrawal confusion, a lot of suicides happened, and a lot of spurious liquor came, and alcohol-related suicides have been quite high. And this is a report from Hindu, which says that there were, in just the 2 months, there were almost 1,500 complaints of domestic violence. And this is much more than what has been recorded in the previous 10 years. So this is an area which we need to do. So economic fallout, particularly for India, is going to be hard. It says that 2 million jobs are going to be lost. We have so many interstate migrant workers and overseas migrant workers who are jobless, who have lost their livelihood, who are not really wanted back also. So this is a potential powder keg of suicide. So what can we do to prevent suicide? See, we have what is known as universal interventions, which means you do the interventions across all levels, irrespective of whether the person is suicidal or not. And as Dr. Shekhar has said, the NIMHANS has been the nodal agency, and he has been the prime mover, thanks to Dr. Alok Mathur, and to produce the manual on psychosocial support during COVID, which Dr. Alok Mathur says we will shortly have. And some of these have been mentioned there. What I would like to highlight is the issue of reduced alcohol availability and consumption, because that has a universal, it is a WHO recommended universal strategy to reduce suicide, and also reduce access to the means of suicide. But what is actually happening, for example, in the US, where firearms is the most common method of suicide, people have gone out and the gun sales have increased tremendously during this time, because people are scared of there may be scarcity of issues and there may be mobbing. So to protect themselves, they've gone and bought more guns, which means that there is more likelihood of many more people dying by suicides by firearm. And then we have selective interventions. And as I said, we have to actively outreach for elderly, because we cannot allow our elderly suicides to go up. We have to actively reach out to them. And we have to provide safe place for victims of domestic violence, even if it is a temporary place. And support for healthcare professionals. These are selective interventions for people who are probably at a higher risk of suicide. And for people with mental health disorders, active outreach, digitally or personally, or increase, all this is very important. Indicated interventions are for people who are already suicidal during this time. Okay. Now, many of the clinicians do not have a defined guideline on how to treat a suicidal person during this COVID. Okay. So it is absolutely necessary that these guidelines are given to the clinicians so that they know during this time how to handle these services. And then we have to increase the availability of services, knowing that more and more people are likely to have suicidal ideas and intents and thoughts. We have to have an increase in availability of services. And another thing is regular contact and follow-up, because we know that a simple, brief intervention and regular contact have reduced suicide, reduced suicidal attempts. Even something even as brief as sending postcards has reduced suicide. For example, in Australia, Greg Carter just sent postcards to people who have attempted suicide, followed them up for 2 years, and shown that those who received the postcards had reduced suicide. So something, it need not be expensive interventions. It can be a simple form of saying that, hey, you matter to me, this card is to check whether you're okay. You know, so that kind of simple interventions and follow-up can be instituted. And safety plans has proven efficacy. It's an evidence-based intervention which is done in emergency department, easily doable, easily trainable, and easily implementable. So this is based on, this is some of the recommendations which have been written in the task force headed by NIMHANS and ably directed by Dr. Shekhar and facilitated by Dr. Alok. And one of the things is to, in terms of alcohol use. Fortunately, from what report we have now, we feel that the consumption of alcohol has come down. Okay. So, which is a good thing for us. So, because many people have been forced into forced abstinence, but some people have sprung back with excessive drinking, but many people have reduced their drinking, and this is something which we should cash on and use positive messaging to make sure that it is not a cool thing to have alcohol every day. You know, there are a lot of other cool things to do, and encourage safe drinking practices and promote moderate drinking habits. The other thing is gatekeeper training. We have a lot of non-mental health professionals working in the community. So all of them can be trained to recognize people who are suicidal, provide immediate support, and provide a referral pathway for those people who are suicidal. This is something which can be done, need not be even in person. It can be done even online if you have the facility. And it can be cascaded down. Each district can have some trainers, and they can go and train the other ashas and other teachers. And this is something which can be done. And the other thing which I would like to say is the COVID has spawned a lot of helplines. But there are many institutions and organizations and NGOs for various reasons, for getting e-passes, for getting mental health support, for domestic violence, for child abuse, for COVID-related issues. So many helplines have started. If those NGOs can be asked just 2 questions, and these 2 questions are from the Ask You questions, which is developed by NIMH in USA, which has an evidence base. Just asking these 2 questions will help us know who are the people who are suicidal, and we can have a daily report and intervene and provide support with brief interventions. And the media, we have a guideline. The last September, the Press Council of India has given a guideline on how suicide should be reported, but nobody is following it. So we can take a stance and pull up the media which are not following the guidelines. And in fact, the chairman of PCI, Dr. Justice Chandra Prasad has said, if there are any violations, please inform us and we'll take suitable action. So it's time we have a media watch, and some have an NGO or a government can have a media watch. Look at all the stories which are being presented, flouting all the WHO guidelines, and report to the PCI, and he says he will take a suitable action. Side by side, we also have to educate the journalists and the media on how suicide should be reported. It should be a joint venture, and we should track this. And reducing pesticide. As I said, suicide is one of the major reasons for method of suicide in India. So we can reduce the availability, access to pesticide, and we can ban. Many countries have banned class 1 pesticides, and India has also banned many of the pesticides. Only a few class 1 pesticides are yet to be banned, and that has been shown to reduce, because once the farming activity starts, which started after 3rd of May, the pesticides becomes accessible. And even if the farmers are working, it becomes accessible to the family. It becomes accessible to other people, and suicides can happen. Finally, before I conclude, I would like to say that whatever be the problem a person has, the final feelings of a person who is suicidal is a sense of loneliness, a sense of helplessness, and a sense of hopelessness. The loneliness, behavioral and evolutionary psychologists are watching how this COVID is affecting us as humanity. There are two divergent opinions. Some of them feel that we will become more inclusive, more inward looking. We will look to protect only ourselves or our immediate family, and our connections and communications and networks will diminish. The other half of the same group feel that this would have brought to light the importance of network, the importance of family, the importance of community, and we will reach out more to this. We do not know which way we are going to turn, but the fact that loneliness is a perception felt by many of the people who are suicidal, and more so now, the COVID has increased this loneliness multiple times. And so this becomes an important factor. So how can we reduce loneliness? See, we say cats and gadgets and all that. But when you're feeling lonely, the only way to reduce loneliness is to have a sense that there is somebody there who really understands me. There is somebody there who really cares for me, and somebody who thinks I'm important. Okay? Which is possible for all of us as human beings. So this is the time for us to reach out to these people. It's the time for us to reach out to these lonely people. It is the time for us to reach out to these migrants, the elderly, and give them a feeling that they are not alone in this, and that we are all together there. And that feeling can be provided only by another human being. So all it requires is a little bit of your time, your concern, your warmth to make another person feel that life is worth living. The other feeling is helplessness. As I said, the external locus is high there, and the COVID exacerbates it. So how can we make them feel that they can control? So any form of internal control, which can be controlling your diet, breathing, sleeping, the way you dress or the way you communicate, yoga, meditation, music, whatever it is. When we feel that we have an increased control over ourselves, we feel more able to cope with things. So whatever gives you a sense of control, whether it is music or dance or meditation or whatever it is, the fact that you can control your emotions is very important. The fact that you are able to control your anger, the fact that you are able to control your frustration. So this would help enormously in reducing suicide. The other thing is hopelessness. See, everything looks bleak. Every day we hear only negative news. And hope is always tied to faith and resilience. So all resilience improving measures and faith in yourself, faith in people around you, faith in the supreme power if you believe in it. Faith and resilience will give you hope. And unless we feel hopeful that we will get over this crisis of both COVID and suicide, we will have more COVID suicides. Finally, I would like to end by saying, Lyndon Johnson famously said that this world has narrowed into neighborhood before it has broadened into brotherhood. Now is the time for us to broaden ourselves both individually and collectively. Thank you.
Thank you, Lakshmi, for the wonderful talk. And I must tell you that in the chat, I'm getting a lot of feedback about how you've covered most of the areas and the fact that, people have learned a lot and you've touched many things. I think just to kind of summarize The most important thing I think you discussed was about uncertainty, about the fact that this is a situation where we are all extremely uncertain about what's going to happen, and that kind of creates a sense of despair, of stress, and being on the edge. You talked about the most important economic causes, and the fact that some people are more vulnerable than the others, like the elderly, people who are subject to domestic violence, people who have relocated. Another important thing that you mentioned was how high COVID dense areas, the rates seem to be higher, which I think is a very good, very important aspect for policy planning and resource planning. Uh, and two interesting factors about how educational policies can change suicide rates. And I think that's one happy kind of a thing in this whole scenario, that a simple educational policy. I don't think when the policy makers were saying no exams, let's take just the marks of the internal assessment, they ever thought that they would make a difference to suicide. But then that's been a fallout. Alcohol related policies have made a difference to and will make a difference to suicide. So I think um, and that's where again like Dr. Alok Mathur mentioned, the importance of looking at how policies particularly related to economics, alcohol and education can actually make a lot of difference. I'm going to ask a few questions. Many questions have come up. um, some of them I'm going to highlight, uh, and this is that there's a lot of online counseling available and free online counseling and helplines available. Someone's asked, and many people have asked actually, why is it that suicides are increasing even though there's so much online help available? So could you sort of just reflect on that a little bit?
The fact is, there are a lot of online counselings available. The issue is, one is we have to see how trained they are, how experienced they are in particularly dealing with people who are suicidal. Okay, dealing with suicidal requires a little bit more expertise than dealing with just queries, and that is an important aspect. The other thing is that the fact is people are more able to reach out for help now when compared to before, and the fact that help is available anonymously helps them a lot. And so it may be an increased ability to reach out for help, and the fact that the services are available. Okay, so I will put it this way: if this online support is not there, maybe there could have been even more suicides.
Yes, that I think that's an important aspect, and I think it's very interesting how mental health professionals have actually risen and providing free pro bono kind of help, and available to people round the clock sometimes. And I think the if you look at the figures of the NIMHANS psychosocial helpline, the number of people who have accessed it, from children, elderly, and we have data now of children, elderly, women. It's just it's interesting to see that if you offer help, how people are willing to actually access it. Some people want to know a little bit about the gatekeeper training and what it really means, and what are the components of gatekeeper training. So if you would like to just emphasize.
See, the gatekeeper training is the gatekeeper is defined as people who are in touch with more people. It could be ASHA workers, it could be nurses, it could be GPs, it could be teachers, it could be what shall I say? People working in beauty salons, anywhere people are likely to interact with more people. And what this training gives you is the fact that when somebody, most often, suicides are most often never a surprise. 70 to 80% of people who are suicidal do talk to someone that they are not feeling like living, that they want to die. But most often what we do is either say, look at people who are less than you and be happy. Or if you are being very kind and sympathetic, we say, take a break, man, go for a holiday or go have a chill out with your friends or something like that. We are not willing to talk to them about it. Okay. So what gatekeeper training allows you is the ability to, your willingness to talk to somebody who is going through a crisis. So its components are usually listening skills, and then following listening skills, it is a certain amount of assessment of the suicide risk happens. So whether it is a low risk or a medium risk or a high risk, and then based on the risk, you trigger actions based on that. If it is severe risk or persons with mental health issues, how to refer a person, or if it is a mild fleeting suicidal thought, how to keep them going, like extracting a promise or safety plans or something like that. Or if it is moderate risk, how to activate psychosocial support, how to get people to support you during this crisis. So depending upon the stage of the suicide risk, you trigger actions. So usually gatekeeper trainings are for 2 days. So it's mostly it is first removing the myths surrounding suicide, then listening skills, the ability to ask the question. See, even now, many people have a wrong perception that if you ask a person who's suicidal whether he is suicidal, you are putting the idea into their head, which is completely wrong. So having the ability to ask the question, the ability to provide immediate support, the ability to assess the risk, and the ability to refer. These are the usual components.
Thank you, Lakshmi. There is a question about youth, whether because of free time, youth going into challenger games and then, going into, trying to think of suicide, or have you had any sort of experience, and what's your suggestion?
We have had, following the blue whale, I'm sure everybody knows about the blue whale. We have had young kids coming to us and some of them, I would say, it is not even a suicidal intent. It is the challenge to do that and score. And there are a lot of other challenges like this, which has made people. And this lockdown has actually, the other point which I probably forgot to mention during my talk is the amount of screen time that kids are exposed to nowadays. The number of children getting into gaming has increased tremendously. And not only that, we find that during this lockdown period, 1/3 of the children using the internet are cyberbullied, and 1/3 of them are suicidal. Okay, the exposure to screen, and there are predators lurking there. And particularly if you have mother and parents who are busily occupied otherwise, these predators catch these young people, and there are many cases. In fact, 2 weeks back, I had an attempt of a young girl of 12 who was seduced online to remove her dress, and they took the photograph and posted it, and it has totally shattered her. So this is a cause for concern. Gaming has increased, internet bullying has increased, predators have increased.
Yeah, so I think the important message here is that, even if young people are online or even older people are online, to kind of be very cautious and careful about, particularly with younger kids, to be very cautious and careful about what they're watching, who they're talking to, and have safety measures in place, which are available. And I think parents need to be, and maybe it's something like an advisory that should go out in a much more active way, because parents don't realize what kids are watching. Another issue is that, they are saying that sleeplessness is a kind of predictor of suicidality in some ways. And now with changing rhythms of people are sort of, there's no exercise, there's no routine. So a lot of young people are staying awake at nights with access to many things. I just wanted to ask some other questions. One was about rural suicide. Are you saying, or do you predict any changes in the pattern of suicide between urban and rural areas?
I am not able to show. I'm not able to be sure, because right now, if you look at it in terms of last year's statistics in terms of urban and rural, there is slightly a little bit more urban rates are a little bit higher, very marginally. It's more or less the same. But I think this would change, and that would be based on the economic fallout. Hopefully, the rural economy is not affected so much according to the preliminary reports. So my guess is that we may be seeing more urban suicides than rural suicides.
I was, just to continue on that conversation, I was reading the Bharatiya Kisan Union report, and which basically said that waiving off of loans, or at least waiving of the installments, has actually made farmers a little bit more, they get a little more relief because they don't have to really do that. And there have been they don't have many functions to do or big weddings to do. So in some way, right now, the farmer suicide rates compared to last year seem to be, at least in Punjab, they have said it's a little less. But then, of course, there is a warning that how it's going to pan out after this. So I think, again, a policy decision of, a loan waiver or delaying installments, how much difference it can actually make to mental health.
I think economic packages will make a huge difference to mental health. Direct cash transfers, waiving loans, extending moratorium, all this I'm sure will have a positive effect in reducing suicides. Because, as I said, it is not most often during economic crisis suicides increase. So if you are able to buffer that, suicide should come.
Yeah, thank you for that. I think that's extremely important. There is also there are some questions about when you see distress on social media, like you're constantly on social media and you're seeing people dying and families being apart, and there's so much of distress being seen. How does that impact suicidality, and what should we do to make sure that we don't get so affected?
See, media has a distinct influence on suicide, particularly vulnerable people and particularly young people. The media impact on young people is nominal. For example, let me quote some figure from outside the country so that I don't cause any controversy. Following the death of Robin Williams, there have been let me just put it like this. There have been enough meta-analysis to know that following a celebrity suicide, people in that age group, there is a definite increase in the number of suicides. And when you're constantly seeing negative issues like this, it has an impact. And particularly when you see suicide-related news, it can have a ripple effect, which is known as the further phenomenon. In fact, we are now trying to see, there is another phenomenon called the Papageno syndrome, where we use media to protect people against suicide. For example, somebody is in crisis, how that person has coped with it and come out. Okay. Now, in the Tamil newspapers, we have made a statement which, when you are putting a person who has scored so much in the marks, okay, put a person who has failed and has made good in life also, so that people know that there are many ways of coping with stress. So coping with any kind of stress, coping with any issues successfully has a positive effect on people. All I can say now is, right now the media is very negative, so limit your media watching. Okay, you limit your media watching just to know what's happening. You don't have to see it constantly. Because what are you going to do sitting in Bangalore looking at what is happening in Manchester saying, oh, 25,000 people have died? Your angst will only increase. Just do it once a day to know what's happening. Otherwise, there are a lot of other things to learn from the media. Using your internet, you can learn a language, you can learn music, you can learn. So many libraries have opened, many people are giving free online classes. So those are all constructive things which can make you feel good.
Thank you, Lakshmi. There is also a question which you kind of addressed about the postcard intervention, that if you have people who have attempted suicide, what is the kind of follow-up that we can give them so that it does not, result in a repeat or a completed suicide?
Yeah, see, this has been done. In fact, we have done what is known as the Supreme study. For example, in Chennai, we had about 680 people who have attempted suicide. And half of them, we just followed them up for the next 18 months, 9 times. Okay. Just a phone call. Okay. Asking, how are you? What are you doing? If you need any help, please contact. This is the mental health professional. This simple contact has significantly statistically reduced suicides and attempted suicide in the people. And as I said, the postcards. It has been done not only in US, it has been done in Iran, it has been done in other places. So the people, which goes to show that a person who is attempting suicide, we always say it's a cry for help. They want some connection, somebody to feel that there is somebody who really cares about you. So you don't need to have, what shall I say, MPhil psychology, or, you don't need to have it. All you need to know is to learn to communicate that you care, ask how they are doing, and if they need help, please contact. The simple 5-minute contact over the period of 18 months has shown, see, it has not only in India, it has shown reduction in Vietnam, Brazil, in all the low and middle income countries. See, we cannot go for high intensive, high resourced interventions like CBT or ABFT or any of those kind of interventions in our country. But these kind of interventions are extremely doable. And safety plan has been known to definitely reduce suicides. And we have used it also in the refugee population near Trichy and have shown that. And it is simple, easily doable.
Lakshmi, you have, worked so much during the tsunami time when there was a disaster, there was a lot of displacement. Do you see any similarities between mental health issues at that kind of a disaster and the current kind of a disaster?
Yes, there is a difference in the sense, in fact, one of the persons whose relative right now today is admitted with COVID, I was talking to the relative and she said, he comes from a fishing community and they were affected by tsunami. Said tsunami is better. It came one day, finished. And then it is all about us coping with it. But this uncertainty, will I get it? Will my children get it? Will this get it? This is driving me crazy. I handled the tsunami better. I knew I lost my boat. I knew I lost this. Okay, but I knew, okay, that is the extent of the loss, not anything more. I can build up now. But here, I do not know what the extent of my loss is going to be. So the uncertainty is what is the difference in terms of mental health. The uncertainty and the fact that it is an invisible thing. Imagine this is a very primitive, the most basic organism with single strand RNA, which doesn't even have a DNA, and nobody knows how to deal with it.
To manage it, yeah. And I guess also the sense of loss of control.
Yeah.
Because, human beings like to have some things in control in their lives.
Yeah.
Now, all of us are just feeling loss of control. So maybe, like you said, to do things to bring back some level of control in your lives. Do things which make you feel some predictability.
Yeah.
Something which you can organize.
Yeah, we all need a routine in our life, even though, however, we crib about it. But the routine is what's going to probably help us now to have some self-control.
Okay, a few more questions. What is, you did mention it, but a little bit more maybe on a family member's role if there is somebody who's suicidal. We know as professionals what we'll do, but as a family member, if you feel somebody is low, somebody is looking terribly down, what is it that can be done?
See, this is a difficult situation in India because if you really look at it, majority of the suicides in India are due to family problems. Okay, so family are the problems. Okay, so but we are used to getting the support only from the family. We are not used to going outside of the family to get support. So when the family itself is a problem and you don't get the support, then it becomes a problem. So most often, I think what we need to teach people here is particularly both the elderly and the young people on how to handle intergenerational conflicts. Okay, the intergenerational conflicts teaching is not there at all, and that needs to be given priority.
Yeah, or just the just parents being able to explore emotions in their children without becoming judgmental or saying you should not be feeling that way.
Absolutely. So that cannot come suddenly when the person is suicidal. It has to come from the beginning.
Yeah.
It has to come from the beginning when you have, parents can't be friends, but they can be friendly. Okay, they need to have a dialogue. They need to have conversation. They need to exchange their emotions, but at the same time, they have to guide them. They have to protect them. They have to show them what is life. So it is a challenge for the parents as well as for the children. Okay, and that has to be inculcated right from young age. It doesn't happen suddenly when you're a young adult or something like that. So both parents and children have to realize that this is the best support system one can get. Both for parents, the children are the best support system, and for the children, the parents are the best support system. So both of them have to be conscious about that and nurture it right from the beginning.
I also there's some question which is related to stigma, and in that line, I just want to ask what you're also member of the National Task Force and of the suicide policy issue about a lot of suicides are happening during quarantine. And that may not be only stigma, it's probably linked to a lot of other issues as well. But what can be done to make sure that somebody who's in a protected environment during quarantine, you're in a protected environment, you're in a hospital, and yet there are suicidal attempts during that point. So what would your recommendation be that health professionals, hospitals should do to ensure that this does not happen?
See, you're in a hospital in a protected environment, but the fact is you're alone. It is a loneliness which kills. Okay, so even if you are in quarantine, how to make them feel less lonely is important. Okay, some of them who are in quarantine complain to me that the major issue they have is they are not used to the food which is being supplied. They are not used to lying in that kind of an environment, sleeping in that kind of environment. Many of them don't sleep. So one of the clue which I would give is, if anybody in quarantine has sleep difficulty, please take it seriously. Okay, many of them have difficulty in sleeping, and most of them have not only fear of them, but fear how have I infected my family? The guilt. Okay, the guilt is what they. So it is important for them to be in constant touch with the family. Make sure the family is counseled, because sometimes the family themselves can be very, very rejecting. And I know for an occasion, the family has said, the man called and said, I'm fine, I'm going to be discharged now. And the family is saying, okay, but don't come here. We have booked you in a separate apartment. Go there for another 14 days and come. So that is the kind of stigma and rejection which affects them. And that may be attempted.
So feeling accepted and not rejected is one by everybody. It reminds me of the time with HIV when there was a lot of mental health issues. Then pre-test and post-test counseling became like a norm. Everybody needs to go through it, and maybe that is something that we need to kind of emphasize.
Absolutely.
In this situation as well, that anybody who gets a test done is actually counseled. It's not just about whisking him away or her away.
And also the family needs to be
the family as well. I mean, now fortunately there's technology, there's video calls, there's so much one can do but so some kind of a guidance note.
And I think was also happening. Even if they come back and they are there, the neighbors stop visiting, the neighbors stop calling, and some of the housing colonies are like fortresses. They don't allow any kind of convenience. And people who are not even, what shall I say, who are not even COVID positive or not even quarantined, but who have just come abroad or come from a particular community, they are being ostracized.
There is one question which is a very big question, which I think you've already answered, but just, I mean, if you can kind of reflect, how can we develop emotional resilience? Because now, like a community resilience, when we're talking about prevention, there needs to be a rethink about how resilience can be brought on in our communities, because this is going to be there for a while. So what are the things that you think need to be there as part of emotional resilience, family resilience, as well as individual emotional resilience?
Individual, family and community resilience have to happen. Individual resilience, the individual resilience, as I said, comes only from facing a failure successfully. So allow the children to face failures. Now the parents are so anxious that they are completely cocooned. They do not know what the difficulties are. They are not allowed to fail, and everything is available to them at the drop of a hat. Okay, make them work for it. Make them understand that life has its ups and downs, and that what makes a successful person is how a person handles the success rather than how he handles the failure rather than how he handles the success. So teach the children life lessons right from the beginning. Allow them to fail. Allow them to work for it. Allow them to understand that there are certain things which cannot be obtained, and we have to accept that. That is one, as far as from the children are concerned. Family resilience is when how the family handles a crisis. When there is a crisis, if the husband flounces off, or if the woman cries and goes off to her mother's house, then the child knows we have to escape from this area. Okay? So how they can handle a crisis? By dialogue, by flexibility, by adaptability, by giving in, and by accepting certain things. So that has to happen in the family. Community resilience is when you feel you are an important part of the community. Everybody, that comes from a very inclusive community. When you ostracize a particular sect, particular religion, particular regional, from where you come from, then you feel apart from the community. Okay? So promoting communal activities, promoting, for example, if you have, for example, let's say you have form local committees for local issues. It may be have a committee to supervise somebody to whether the streets are clean. No, somebody does that, or somebody who will see that the school
buses. In some way, COVID has taught us that we need to be much more connected to each other than what we have been in the last decade.
Hopefully, that is the lesson which we learn.
The other thing that I wanted to ask you was, you have one of the most popular helplines in the country. What has been the difference in the kind of calls you're receiving now as opposed to earlier?
What we are receiving more people feel trapped. More people feel trapped. More people feel that they cannot get out of the trap. Okay, and what I'm seeing is people who have been completely stable breaking down now. For example, we had a person who was completely living a very social life, and this COVID has completely changed, developed, depression. So this has definitely caused more people having psychological disturbances than before. That is definite. And the primary feeling is, again, a feeling of being trapped and the uncertainty of it. Even husband and wife, they say we fight. I used to go out. Have a meal with my friends, and then when I come back, I'll be mellowed. Now it kind of feeds on itself, and we are just the fights are becoming worse and worse.
There's, you talked about healthcare professionals, and I think that's, there's a concept which is being called moral injury, that people are not health professionals are finding it very hard, and it's not just health professionals. I think it's in the police and policy makers everywhere, where you have to take something from one pot to give it to another, and you feel you're not being really fair. Would you like to kind of talk, and that is becoming a big issue for a lot of people? Would you sort of highlight a little bit on that?
Yes, as I told you, it is a challenge, as I said, not only for police and doctors, but even for health workers, sanitary workers, and so on and so forth. The person who sweeps my streets says, I feel very bad because in that house they had COVID positive, and they have just put the mask on in the waste paper basket. Don't they have any sense? I said, why don't you ask them? I said, Amma, how can I go and ask them? They are all big people, rich people. So the lack of awareness on how your actions can impinge and impact on other persons is something which we have to think about. Regarding a question of moral injury, I think that is a cross which we have to bear. Because I don't have an answer, honestly, Prabha, for that. Because there is, on one hand, see, for me, let me be personal here. See, in my hospital, we are treating COVID, and we are counseling COVID relative, and I see people who are COVID. Okay, when I come home, I immediately want to go to the bathroom, change, wash, and all that. And my grandson comes running back. Till now, he's used to me coming back, lifting him up, throwing him up, playing with him for 5 minutes, and then going. Now, as soon as he comes, I run. So he becomes perplexed. He just stands there. He's uncertain what to do. So next time when I come, he runs, stops, looks at me, what I want. So, and as a perinatal specialist, you would know that many COVID mothers are separated from their young infants. They lack the touch, they lack the thing, and what kind of impact this would have, we do not know on the mother and on the children also. We have many, many, many COVID positive mothers who are separated. They are not able to lactate. They are not able to do all this. And that is also a huge problem.
Another concept which is coming, which is being talked about a lot, and I'm wondering how we as mental health professionals need to help with that, is what is called disenfranchised grief. That is, there is grief, but you can't talk about it, you can't emote, and it's not just about death, but it's about so many losses. Everybody's losing something, so you don't feel you feel guilty even talking about that grief, so that grief is not dealt with. So and that kind of becomes very internalized, and people can start brooding about that.
Absolutely. It's not only disenfranchised grief, sorry. It is also that you don't get a closure on people who have died. Okay, the fact that you're not able to do the rituals, you're not able to be there. The people who are having COVID have just taken away. One moment you see them, and then they are taken to the hospital, and then poof, they are not there. So you're not able to grieve properly. Okay, even you're not able to pay your respects properly, and even your friends and family are not able to come and be of support to you during your grief. That is one aspect of it. The other aspect of it, as you rightly said, is not only the grief of the person, it's the grief of what he has left us with. That also causes a huge issue. And the fact that because of this, you are asked to vacate from the home, and you have to move because you can't pay the rent because the head of the household has left. And nobody is willing to give you a house now. So you're literally on the road. So very one loss triggers, it is a domino effect of so many other losses.
Yeah, and I think as mental health professionals and those of us listening in the audience, I think we need to kind of be aware of all this, this whole network of challenges that everybody is facing when we are trying to support them and help them. It's not just the job loss, or it's not just the fact that I was not able to get admission into a college which I wanted to because there is no college right now, but a whole range of emotions which are there. I, as somebody who is part of the National Task Force and focusing on suicide prevention, I want to ask you about, what do you think should be our 3 messages to the government to kind of say, you know what, do this and we may see a difference in suicide rates?
I would say 3. One is make, as I said, the helplines. Call anybody who calls a helpline, ask a suicide question, and provide contact and follow up. That would be my first thing. The next would be to ensure reducing alcohol availability and consumption and reducing pesticide consumption. And the third thing would be to look at our policies and look at our educational policy and policy for reaching out for help. Making health systems more affordable, approachable, and people friendly.
So, so just to kind of repeat, you're saying that one.
Sorry, I cannot finish it without talking about the media. Ensure that media does not sensationalize suicide.
Yeah, so I think basically you're saying more helplines, and that's what is needed. More training, more gatekeeper training of every frontline health professional or non-health professional who comes in contact with different people. So maybe having more services available, better policies, less access to methods by which somebody can harm themselves. And of course, a media watch is what is your sort of your message about how we can actually make a difference. Are there countries where this, during the COVID time, there's been some kind of a difference? Have there been trends that some countries are able to manage this better than other countries during COVID?
As I said initially, some of the countries, but then Japan and New Zealand had less COVID, so we cannot really.
More, yeah.
And so we cannot really say that. But Thailand seems to have managed it better, and Thailand has probably managed it better by keeping the networks open and increase access to help.
One of the things that you mentioned, and I think this, if I'm going to say like a take-home kind of a message, is there are a couple of them. One is you mentioned something about a media watch, and to all the 500, 600 people who are watching right now, it's one thing, you open the newspaper, you open your website, and the first thing which strikes you is somebody jumped somewhere and a lot of details and everything. What can people do? What can we do? You mentioned that there is a method by which we can have some redressal, but is there, if I feel that if all 600 of us keep doing it again and again and again, and I know there's been some success in changing terminology. Many newspapers have moved from committing suicide to dying by suicide. So at least that change has happened, even if minimal. So what is it that your message would be to each of us who are watching today? What can I do to make that difference?
I think what we should do is to write to the paper, write to the journal, say this is harmful, this is affecting us. Please at least give the helpline numbers, whatever helpline numbers, government, there is 104, there is so many other lines. Okay, give at least a helpline number when you publish this. You don't need to have a photograph. Okay, all of us, if everybody protect, if it becomes a groundswell of people's movement, I think newspaper will take a.
I think if one thing that COVID can achieve, and from the government side, the policy side, as well as from like a civic movement kind of a thing, a groundswell or like a rising of some sort, that media needs
to be. What happened in HIV? I hope this happens for COVID suicides also. Right. There was a groundswell of people movement, and there was policy decisions, there was media support, and the combination of these three was what what was helpful. And if those three can happen now, I'm sure COVID suicides would come down.
Before I kind of wind up, I'm going to ask, if Dr. Anish or Dr. Pandyan, Dr. Shekhar, any of them have any question to ask, because I'm going to give my sort of final comments. But is there any question that is there from your side? Is there anything that you need to ask? Dr. Atri, I can see her. She's. Would you like to ask some questions? Is there anything you want to discuss or ask? I think we would love to hear from you.
Okay. Good afternoon, everybody, and thank you so much for giving me this opportunity. A very, very pertinent and a very timely, workshop, because I feel that suicides are something which we really need to address at Right Earnest. I feel that, Dr. Lakshmi has really more than comprehensively dealt with the topic. Nothing more to add, just would like to emphasize on a few things. One is, am I audible?
Yes, you are.
So,
you are.
Yeah. So firstly is like, I mean, I totally agree that stigma and discrimination against mental health conditions are, preventing people to access help. There is, more and more need to tell people that it's like any other illness. Mental health should not deter people from accessing help. Secondly, also, during COVID times, restricting ourselves from media junk, I would say, because we should only, access dependable data and not just look up anything and everything and feel, tensed. And thirdly, of course, strengthening our health systems. And I think from NIMHANS, there has been a lot of effort in this. And we are really grateful to NIMHANS for that. And Dr. Lakshmi also, with her guidance to the the suicide prevention strategy, which is under the making, and also the psychosocial action plan. The health systems, particularly, training. I think mental health should not be just limited to the cadre for district mental health program, but all across all programs should be given few tips of how to identify depression. And people can be, all the grassroots workers should be trained how to identify depression and other psychiatric common illnesses, and so that there is early referral, early management, and many precious lives which are actually getting lost due to suicides can be preserved. So thank you so much, and again I congratulate NIMHANS for this great effort.
Thank you, Atri. I just want to end, Lakshmi, with asking you, can the government have a policy of hope? Because one of the things you mentioned was the sense of hopelessness. And there's been some discussion in the chat box about that when you have somebody who's really hopeless, who's decided they want to end their life. But I want to take it a little bit more, more radical and more tangential thinking at a time like this, where all of us, even the best of us with resources are tending to feel a little worn down, and a sense of doom and dismay and hopelessness. Is there any sense in the government thinking of policies that instill hope? And if you were asked what were those policies which will instill hope would be, what would you say?
That's a tough question, Prabha.
Maybe all of us should think about it. But I'm just thinking.
No,
because
but see, hope is a sense of feeling good about yourself, good about situation around you, and good about what's going to happen in the future. Okay, so if the policies are there which encourages individual expression, which it encourages ability for an individual to actualize their potential, that will give us hope. Okay, so every individual, whoever is the individual, if the person feels that you can actualize whatever is your potential, that will give you hope. And also the fact that if you are able to work productively and usefully, so that can be also a policy decision to provide productive and useful employment to people would give you hope. Okay. And at a personal level, what really gives you hope is a little bit of altruism. Do something for other people without expecting anything in return. You know, even if you help a visually challenged man across the road that day, you feel a little bit better about yourself. So a little bit of altruism also helps. I think these are what could be done at a policy level. A personal level, I think a little bit of altruism. At a policy level, providing adequate work and providing an opportunity for individuals to actualize their potentials.
Thank you, Lakshmi. On that hopeful kind of note, when all of this is going on, I'm going to end the session. It was a wonderful session. As always, Lakshmi has so much wisdom in this field, and I thank you, Lakshmi, for being with us during these difficult times. I would like to wish everybody a good evening, and please stay safe. And I hand it over to the organizers to conclude. Thank you.
Thank you very much, Madam Dr. Lakshmi Vijayakumar, Director, Sneha, Chennai, for the great lecture on this day. In fact, it's a wonderful day. The ministry has come out with the guidelines. We are extremely thankful to you for your valuable presentation today. I'm very, very confident that the entire team enjoyed this program, and we are all hopeful about this wonderful activity. I'm extremely privileged to convey my sincere thanks to the chairperson, Dr. Prabha Chandra, Professor of Psychiatry, NIMHANS, Bangalore. Madam was our former HOD of the prestigious Department of Psychiatry and currently the chief of the NIMHANS Center for Wellbeing, and Madam also heading the perinatal mental health clinic and works continuously in the field of women's welfare. I am extremely grateful to you, Madam. I sincerely thank you on behalf of the entire Department of Psychiatric Social Work and NIMHANS and all the professionals from all over the country for your valuable contribution. I sincerely thank both of you for your great contribution, Madam. It's a great honor for me to sincerely thank Dr. Suresh Badamat, Professor of Psychiatry, in charge of Forensic Psychiatry and Telemedicine Services of NIMHANS, for all his technical support and extended his collaboration for the successful conduct of this program. I am extremely grateful to our beloved Professor Padmasri, Dr. B.N. Gangadhar, Professor of Senior Professor of Psychiatry and Director and Vice Chancellor of NIMHANS, Dr. K. Segar, Professor of Psychiatric Social Work and Registrar of NIMHANS, our Deans of NIMHANS, very especially the Dean of Behavioral Sciences, Dr. Sadi Chandra Grimaji, Senior Professor of Child Adolescent Psychiatry, all the HODs of the department, very especially Professor Pratima Murthy, Professor and Head Department of Psychiatry, Professor S.K. Chaturvedi, our former Dean, Dr. Seema Megalhotra from Department of Clinical Psychology, and all the faculty members from all the departments of Psychiatry, Psychology, Psychiatric Social Work, Psychiatric Nursing, Mental Health Education, and all our allied departments for all their support for the conduct of this national level seminar. I am extremely grateful to the Ministry of Health and Family Welfare, very especially to Dr. Sri Alok Mathurji, from the Director General of Health Services, Government of India, New Delhi. I am also extremely grateful to Dr. Atreyi Ganguly from WHO's Country Office, New Delhi, Sri Nilambuj Saran, and Founder Economic Advisor from the Ministry of Health and Family Welfare, Government of India, and also Mr. Sri Piyush Ji from the Ministry of Health and Family Welfare, Government of India, and all our other members from various departments of NIMHANS, very especially Sindhu from Biomedical Engineering team, all the institute, NIMHANS Institute staff and colleagues. I am extremely grateful to my entire team, the architect of this entire program, Dr. Anis Vicherian, my colleague. I have the great honor to sincerely thank Dr. Anis Vicherian for consistently working in the area of suicide prevention and having arranged this wonderful webinar. I am also grateful to all my PSC scholars, psychiatric social workers, Ms. Akanksha Rani, psychiatric social worker, Mr. Bharat and Lakshmi Vimala, PSC scholars, Kathy Rosani, Ms. Anjana, Ms. Sangavi, Ms. Arya Trimeni, and many other young colleagues